Why don't we start and hopefully we get some more people trickling in, but again, it'll be recorded. So thanks everyone for having me. I think I've met most of you guys, but my name is Crystal Wong. I'm a family doctor. I practice at UWPC Ravenna, and I've been with the University of Washington since 2007 when I came here for residency. And I'm the Associate Medical Director for Digital Health. And we also have Mika Makinen here today, who's one of our internal consultants for digital health and has been partnering with me on a lot of the remote patient monitoring work. So today we are going to talk about continuous glucose monitoring, which I know has been available to us in primary care for quite some time. I remember Savitha coming to my clinic and training us, I don't know, 4 years ago. It was a long time ago, but I think with a lot of things, when it's just another additive doodad to consider in your practice without kind of institutional supports, it's difficult to integrate. So I'm happy to be here today with a program that's not just here, provider, think about this yourself. There is a little bit more workflow, Epic tools, et cetera, to enable you to use this really, really powerful technology in your practice, hopefully easier. So that's what we're going to do today. Let me get my slides advanced. There we go. Okay, so I don't think I need to explain this to you, but we are living in a world where our population is more and more digitally connected. We're living in a world where we're even doing telemedicine to patients that maybe don't even necessarily want telemedicine. There have been times in the pandemic where we have forced people to do telemedicine. So, our populations, are moving to use those types of technologies kind of sometimes whether they like it or not. But, for me, with my digital health hat on, I guess, what we're trying to do in digital health is expand your toolkit. So for patients where it would be a good fit, you have something that you can reach for. I'm sure all of you have received data from patients using devices, whether or not you ask for it. I know whether it's an Apple Watch or a Fitbit or all sorts of interesting things, patients are tracking their own metrics at home. I do think that this is just a real fabulous opportunity, though, to take the care that we provide traditionally in the office into the patient's natural environment where they literally spend most of their time, as opposed to the small fraction of what you see in your office. And certainly chronic disease management, especially for conditions like diabetes, you make the greatest impact at home, not in the office. There are some other things that we're looking at as potential benefits, of using, home-based care, such as, maybe reduction of in-person visits, maybe saving your hard to come by face-to-face time for patients that do need that visit for you to, lay hands on them, et cetera. But I would say that those are kind of secondary to our primary goals, which is just to offer the patient another option that will keep them engaged in their care and meet their individual goals. So this is the agenda for today. We're going to talk through the workflow. We're going to spend some time talking about inclusion criteria from a medical perspective. We're also going to talk a little bit about insurance coverage, which is very confusing. And I think you guys may have heard, we ran a CGM pilot kind of in, oh my gosh, what year is it? In mid to late 2021. And I would say the insurance authorization part was probably one of the stickier areas that, we put some more work into moving to this phase of actual rollout throughout PC. We're going to talk a bit about just kind of the nuts and bolts of what you have to do within Epic to get this program started. We'll talk a bit about the facilitation of care that your nurses will do for you. And we'll talk a little bit about interpretation of CGM reports. It's not by any means going to be exhaustive, but I do have a link to a fabulous presentation that Savitha gave for the pilot clinics on how to interpret CGM if you want a refresher, and that's about an hour long. There's also a link at the end of the presentation to a video from Abbott, who's the manufacturer of the Freestyle Libre. That's pretty succinct, but also covers a lot of really good data from a provider perspective. And that one's about 13 minutes long if you want an abbreviated version. And then we'll talk a little bit about billing and coding for these services. And then I also just want to mention, please keep it casual. If you have questions, feel free to interrupt me. Mika will also be keeping an eye on the chat if something comes up. And hopefully we have a little bit of time for questions at the end too. Okay, so here's a Visio. I don't expect you guys to go step by step by step, but I think the things that I want to highlight is, we're really looking at making diabetes care team-based. And you can see in this diagram that we've got what we call swim lanes for all sorts of people in your clinic, whether it's your clinic MA or your RN or RD. The patient has their own responsibility as well. What's the provider part? And, as you work on pop health and panel management, definitely want to include those members of the team there. One area, again, that we put a lot of work into before bringing it prime time is this area that I'm kind of circling right here. And this is about getting things covered for patients. I know you guys see quite a few patients who have Medicaid and Medicare, and insurance coverage can be a little bit sticky, but we do have support for that now if you're trying to get insurance coverage for the equipment for these patients. All right, so let's first talk about identifying patients. I think one of the things that we've learned both in our internal experience with remote patient monitoring and also in collaborating with other academic medical centers who are rolling out RPM, that it's incredibly important to identify the discrete group of patients that you're going to be focusing your efforts on. And just have real clear boundaries on the program. Both from a evidence-based medicine perspective, but also for a not scrambling every single person's brain who's trying to learn something new, not putting extra pressure on your poor nurse that's doing 5,000 things in addition to being willing to help you with this. So I want to make sure that we're all very clear about what types of patients that will be a good fit for this program. So this picture is of a cat wearing a Freestyle Libre. This is actually Erin Beckstrom's cat. If you ever met her, she's the manager at SLU. And her cat was prescribed one to profile his interstitial blood sugar because he was acting funky. And it turns out her cat did have diabetes. We are not going to be enrolling cats, although if you have pets and you go to the vet and they're acting funky, they might get one of these. But who are we focusing on for this program? So we are going to focus on type 2 diabetes in primary care. Continuous glucose monitoring is absolutely standard of care for type 1 diabetes. All the endocrinologists are using it. Our endocrinologists here at UW bill out almost $500,000 in CGM codes a month. So it's obviously widespread. I know all of you take care of patients with type 1 diabetes who may or may not be seeing endocrinology for a variety of reasons, but we're not going to include them in this program because, again, this is a staff-supported program as well, and type 1 diabetes is just very different and would complicate standardized workflows. So, you may have a patient that CGM is a good technology for them, but in terms of this standard program, don't enroll them into this program, but you can prescribe CGM for them. I think one other thing to emphasize for us in primary care is oftentimes we think CGM, we think insulin, oh, this is just a good way to avoid finger sticks. And that's true, but that's not it. So this is a great fit for a patient who has type 2 diabetes on insulin, but you can absolutely use this in patients who are just on oral meds or even maybe not even on meds. Maybe they're newly diagnosed and they really want to do lifestyle. You can still do CGM. Now, not to be confused with insurance coverage. I think that's where it gets a little sticky sometimes as practitioners. Oh, it's not covered, so I can't use it. You can use it. We just have to be a little bit savvy, which I'll go through in the next slide. So this is an incredibly powerful tool for patient engagement. Your patient is turning over a new leaf and is going to go on a low carb diet. Your patient just had diabetes teaching and now knows how to carb count. Your patient is recommitted to exercise, whatever it is, not just, titrating meds, although it's a really excellent, tool for that too. So, I guess I would just encourage you to think about this for any patient who has type 2 diabetes, regardless of severity, regardless of um, medication plan, if this is a good fit for them in terms of, their um, cognitive perspective, in terms of their, degree of comfort with devices, et cetera. We do have some exclusion criteria. So again, type 1 diabetes, we're not going to be including them in this formal program. Gestational diabetes, I know you guys don't practice OB, but we do have some FPs and PC who do obstetrical care. Pediatrics, so we're not going to do kids. And then also patients who are seeing endocrinology for type 2 diabetes. If you have patients who have type 2 diabetes and see an endocrinologist and are interested in CGM, have them talk to their endocrinologist about it. Number one, their endocrinologist will be vastly, very, very familiar with this technology. And the reason why we decided to not include those in our pot is because of the billing component. The codes that you use for this can only be billed one time a month. And we thought it would just be too many cooks in the kitchen. What if the endocrinologist bills it and then you bill it and the patient gets a bill because, it's billed twice. We wanted to prevent some of that confusion. And then, just consider about, integrating this into your pop health. If you're having panel management meetings, this is a great tool to consider when you run your diabetes list if you have someone with care gaps. All right, so let's talk about the elephant in the room, which is insurance. This is the current state grid of how payers cover CGM equipment. Let me highlight equipment. The equipment needed for continuous glucose monitoring is for the vast majority of patients just sensors. It's just kind of like how drug companies, they make the money on like the glucose strips, right? They don't make it on other things in diabetes. It's the sensors. Now, if you have a patient who does not have a smartphone, you do have to prescribe a reader as well. So that would be also construed under the equipment portion of CGM. And we will talk specifically about how to order these things in a couple slides. But this is current state. As with a lot of covered benefits, hopefully this gets a little less restrictive as time goes on. As this becomes more and more frequently used, as patients advocate for themselves and want to use these technologies. But this is current state. So for commercial insurance, so your Regences, your Blue Crosses, your uniforms, et cetera, all you need is any diagnosis of diabetes. You don't have to be on insulin, doesn't have to be very severe, don't have to even be on meds. You just have to have a diagnosis of diabetes. I would have to say, and you guys are all as familiar with this as I am, patients that have high deductible plans or, poor drug coverage in their plans, sometimes they get a little bit of a nasty surprise when they go pick this up at the pharmacy. Their insurance says, oh, it's covered, but they go to pick it up and it's like $300 or something, if that's the case, I think we're all kind of facile at being like, run it under GoodRx or see what the cash price is, or call Target or Costco and see how much it is. So we'll talk through some tips and tricks. But if you have someone who has commercial insurance and they get a surprise at the pharmacy when they go pick it up, then we'll move down that route. For Medicare, patients do need to be on insulin, and they have to be on at least TID insulin. So if you have patients who are just on basal Lantus and don't need prandial insulin, their equipment is not going to be covered by Medicare. There's also this kind of little bit arbitrary needs frequent insulin adjustments. That's more about chart documentation than anything, that is that quantifiable. So we do have some smart text for you guys to use if you're going to do this program that has a bunch of documentation language like, this is medically necessary for this patient. The patient needs frequent insulin adjustments, that type of verbiage. And if you have a patient who, doesn't meet those criteria, for instance, like type 2 diabetes on oral meds, et cetera, you can just delete that stuff out. But we did put it in there for the sake of the prior auth team that would be helping you guys get coverage for patients that have these types of insurance. And then Medicaid is the most restrictive. So not only do you need to be on TID insulin or more, you need to quote, need frequent insulin adjustments, but you also need to be telling the patient that they're supposed to be self-monitoring at least 4 times a day. Again, it doesn't have to be like documented, that the patient is actually, checking their chem sticks 4 times a day, but you have to have that in your chart that you have recommended that they do this, whether or not they are actually doing that in real life. Okay, so that is a lot of work. We do have the prior auth team, the same team that helps with prescription prior auths, is going to help with this in patients that need it. But I think you can tell by the tone of my voice, there may be an easier way, which is frankly cash payment, because there are some ways to get this covered. Libre often has a coupon for 2 sensors. Each sensor lasts 2 weeks, so 2 sensors is a whole month. And for a lot of patients, you're only going to do short-term profiling. They want to make a change, they want to change their med or whatnot, and they just want to see what happens, and you're not going to do this forever. And so that might actually be a good option. I just had a patient who's on Medicaid who wanted to do this. She has type 2 diabetes on meds, and she was able to get 2 for free from Libre. So that was cool. We did it for a month. She learned some cool things, and la-di-da. The other trick is for your patient to just ask the pharmacist to check GoodRx. Typically, GoodRx has 2 sensors for $70. Sometimes it varies a little bit pharmacy to pharmacy, but you can get a month's supply of sensors often for as cheap as $70, which for a lot of patients, the information is worth it for them and they're willing to pay cash. I do want to mention, although this is like less pertinent for you guys, but the RPM codes have actually been well covered by all insurers. We actually ran a hypertension pilot, which so not even for something like diabetes. And we got 0 denials from commercial Medicare and Medicaid for hypertension RPM. So really all you need to worry about in terms of insurance coverage is for the equipment itself, not for the, your fee for interpreting it, or, in our clinics that are billing incident to, they don't have to worry about the nurse's time billing that out, whatnot. Payers have been pretty good about covering that. All right, so why don't we dive into the workflow? Maybe before I do that, I can see if there's any questions about equipment cost or inclusion criteria for this program. Okay.
Actually, could I just real quick? So your sense though is like extremely broad coverage for commercial insurance people just with the diagnosis of diabetes.
Yep.
Okay, so maybe some exceptions here and there, but generally speaking, covered.
Yeah, in fact, we actually, Alison Everett and her team of RDs have done a lot of inquiry and has been working with UWP, and uniformly commercial covers it for any diagnosis of diabetes. The catch is just how much is it going to be with it being a covered benefit. Yeah, we actually haven't had a lot of any complaints. I haven't received any complaints from patients around coverage for this, except for those times that I've heard from nutritionists like, oh, it was surprising. And so they decided to just pay cash instead because cash was cheaper. All right, so let me walk you through step by step what you're going to do if you want to enroll a patient in this program. So most of the time, this is going to happen in a clinic visit, whether that's in person or in telemedicine. You are following up a patient who has pre-existing diabetes, or maybe you're following up a new diagnosis of diabetes and you're talking to patients about their options. So if you feel like this is a good fit, there are a couple things for you to do. One is to document a consent for RPM. We were trying to mimic the workflows that we use for things like consenting patients for e-consults or consenting patients for BHIP programs, as to kind of, make this in a mental paradigm that kind of makes sense for you in your day-to-day clinic life. So we have a generic consent, the .rpm consent, and we do have a job aid that I'll show you guys later in the presentation that has all of the smart text for this program aggregated in one place, so you don't have to, remember all these words. But .rpm consent, it's a generic RPM consent. It has to be done once a year. In the future, we're hoping to have lots of other RPM types programs up running. One other one we're really putting some work into right now is hypertension. So if you have consented a patient for diabetes and then you want to do hypertension later when it's available, you don't have to consent them again. It's already in there. But that's a consent. And you can consent via phone call or back and forth my chart message as long as the patient has, written, clearly in my chart that, yes, I want to be included in this program. You can include that consent with that. And then you're going to place a referral. There's a referral to remote patient monitoring, and it has a drop down right now in it where you can hit the F2 and then choose CGM. Again, we're hoping to add other programs. So in the future, if you're doing referral to hypertension, then you would choose hypertension instead, et cetera. And then if you guys like, there is a AVS dot phrase, for patients who, you're meeting with them and they've agreed to be part of it and you just want to have like the expectations, like what's going to happen next, what do you need to do? What is this program? You can use that, and it's got some FAQs about the program. And then please CC this encounter to your RN who's going to be supporting the program, so he or she knows, what is going on, what the diabetes plan is, like we're going to do CGM, the patient's going to start metformin, we're going to watch it for 2 weeks, et cetera, whatever you decided for this patient's plan, because they're going to be a integral member of the team to kind of do some communication for you. So the consents in the referrals and now you need to get the patient their equipment. So this is a little bit funky. For most insurance, commercial and Medicaid, you're going to order this like a medication. So just in the orders, little box on the bottom, you're going to type in Libre or Freestyle or whatever you remember it as, and it's going to pop up some Epic orders. I'll show you that on the next screen. And then you have to decide what quantity you're going to prescribe for them. Frankly, I've only enrolled patients who are not on insulin right now. And so I've been giving them pretty short-term prescriptions, like 2 sensors with 2 refills, something, like a couple months. If you had someone where this was going to supersede, their typical chem sticks and they're on insulin, and that this is just going to be more of a forever plan, you could give them, 6 sensors with 4 refills, like you would for, glucose strips or whatnot. But typically I've been doing kind of more short-term fills. Medicare pays for this in patients that are qualified through DME. So it's a little bit funkier. So you need to put that in your head, like TED hose or diapers. So there are a couple things that you can do. One, you can put in a DME order. Personally, what I do, because I don't like having to think about multiple things, is I still order it like a medication, but I just print it as opposed to e-faxing it. That way, it comes out of the printer, it's on the watermark paper, and I just sign it and I tell the patient, you need to bring this to a medical supply company to get it from them. There is also a required DME form. It's hyperlinked on this slide here. It's also in the smart text. So if you blow the smart text into Epic, for just documenting, the program, the link's actually in there. It lives on the UWPC intranet, so you could also just print a few copies and keep it somewhere, or save the hyperlink somewhere on your computer and your favorites, whatnot, and get it that way. But it is in the Epic tool as well. And then you do have to fill that out, and then the prior auth team has to send that in along with your chart notes to get it covered. So again, it is kind of a lot of hoops to jump through, but that is life. And then this is just a reminder, again, if the patient doesn't have a smartphone, they are going to need a reader prescription as well. Jenny, do you have a question?
I do, Crystal. I'm sorry. Yeah. I'm feeling like I'm just not getting something. When you refer to the program, I'm sorry, can you clarify what that is? I'm not sure that I know what it is.
Yeah, we're actually going to go get into some of the slides about what your nurse will be doing. But so I would say, CGM is obviously a tool that you can use, but one of the barriers that I've heard time and time again from providers, and frankly, like why people like me, like I have not used it since we developed this program, is there's a lot of between care that needs to happen, right? You have to have an account password and you need to go get this report and then you need to go to Epic and like all this stuff. And frankly, I've just have been unwilling to do that, you know, because my focus is on seeing patients. So this program is an encapsulated program where there actually is staff support for doing that. And you can totally do CGM outside of it. Like, again, like I mentioned, like type 1 diabetics who you're taking care of by all means, but we didn't want to put that on the staff for learning something new, you know. So anyway, so that's what I'm referring to. So I'm going to call it like the program, meaning meaning that as opposed to just CGM, whatnot.
Perfect. And just to clarify, we have that program available to us here at GIMC.
Yeah, I think that's where Jake and Candace are trying to figure out where your staff has bandwidth because unfortunately, you know, since you're hospital based, you can't build a time incident to. So, you know, at my clinic, for instance, we're non-hospital based, my RN is billing for all his time, you know, so it is like kind of a cool pathway to shore up the clinic staff for things like this, right? It's revenue that isn't typically collected by those staff members. You guys have a different billing structure. So I think it's really kind of about juggling resources. And so, you know, I would probably just check in with Jake and Candace. I'm sure you guys have put in a lot of thought into like what you can and can't do.
Yeah, and I could just add now, I mean, we went through that big workflow, Crystal, that you pulled up a little while back and just kind of looked through box by box, figuring out, you know, what could our nursing team reasonably potentially take on versus not. And our nurses have gone through the RN orientation for the program. And we're very interested in engaging and participating as much as possible. So Kate and Candace and I and the nursing team have been working on that piece of it. Still to be finalized, but we're hoping to have some sustainable team-based approach.
Yeah. You know, one question, you know, I think you guys are like, I can't remember how many clinics I've trained. I want to say you're like number 11. You know, one of the FAQs we get is how many patients can be in this program? And that's so dependent on your nurse's workload, whether you have an RD supporting. I mean, we just got that question from the Montlake Terrace Clinic, so formerly the Lake Forest Park Northwest Clinic. So we just trained them, and their RD was like, "Oh, this is super easy to me. Like, don't worry about it. You know, I'm experienced, but you know, this is a new program. We don't want to overload people. So I expect that, you know, that's going to be a little bit of a learning curve, and you know, potentially the beginning." If you, I don't know, if everyone all of a sudden sends a ton of patients, you guys may have to kind of be like, I don't know if we can carry that many right now, and you know, figure that out.
And what I hope is a really quick question. So many of our Medicare patients do have like a region supplement.
Mhm.
And so
Yeah.
that will just sort of automatically kick to the region supplement and be covered.
Med Advantage covers
Okay.
this stuff really, really
Okay.
well.
Okay.
So, and actually the hypertension pilot that we ran was actually a Med Advantage pilot. Regents actually gives a grant of $50,000 to get all of their patients' blood pressure cuffs. So, you know, Med Advantage plans are very much on board with these types of plans. All right, so here's what the Epic orders look like. This upper left corner, very small, is the reader. So if your patient doesn't have a smartphone, you got to do that. It kind of looks like a glucometer. And the bottom one is sensors. So again, I usually do 2, maybe with 2 refills. You can do more, you know, if you think the patient's going to use it long term. Okay, so what happens after you did all of this? So you've done it, you consented the patient, all the magic that's going to happen so that you can just be a doctor instead of like a administrative secretary. Okay, so your referral to remote patient monitoring goes to what's called the care management work queue. It's actually what the nurses are working already for care management referrals. I don't know exactly, Jake, about how that works at GIMC, but that's where it's supposed to flow. So then, you know, it alerts your nurse that there is a referral in the pot. Then your nurse is going to go into the patient's chart and make sure everything's in there. You put the consent in, obviously the referrals in, because that's how they got it. Hopefully you have already CC'd the patient's chart to them, so they have been expecting that referral to show up, and they kind of know the status of the diabetes plan. And then they're going to check and make sure that you remembered to order the equipment. I know I've totally forgotten to do that before, and so they'll ping you and be like, hey, Crystal, can you please order the sensors? You forgot to do that. And then once that's done, they're going to contact the patient and make sure they got their equipment. Because for most patients, they'll have received it. Some patients, it might be stuck in the prior auth workflow, who knows? And then they will be able to circle back with, the prior auth team or the patient or the patient's pharmacy or wherever it's stuck, and help them with that. Once the patient actually has their equipment in hand, the RN is going to schedule a RN intake appointment. That RN intake appointment is predominantly for device teaching. And we'll go through that in detail, the contents of that visit in a couple slides. This is just, again, more of the sausage making that's going to be happening behind the scenes. But, the prior auth team will help make sure that the packet of stuff is prepared for the insurer, basically your chart notes, the DME form, et cetera. So that was a lot of kind of nice partnering we were able to do with that team in between pilot and good to go stage. So there's that. So the patient has their equipment, they're here for their intake. The predominant thing your RN's going to train them to do is how to put the sensor on and how to sync it to their reader. And there's a lot of little tidbits, like reminding the patient that they need to sync it at least every 8 hours, otherwise they lose their data, reminding patients that, this could potentially interact with the sensor, et cetera. So there's a lot of device teaching, and it kind of depends on how digitally savvy the patient is on whether or not this is going to take the whole hour, or if they're going to be able to get to part 2, which is kind of goal setting, history taking, education component. If you have a patient who's really needs the full time just for device setup, then your RN will schedule kind of a second meeting with them to do the rest of the teaching. But predominantly the focus is going to be on how to use this device and how to be comfortable and confident with it at home. And there's actually a special code that the RN bills for this visit. Obviously, again, you guys can't do that, but for those in PC, there is kind of like a nice specialized code just for device setup. And then again, let me just highlight again, these bolds are coming from Allison Everett in the diabetes team. She says, please make sure the patient care plan is relayed to your RNRD, because they're going to be, reiterating that with the patient on your behalf. Okay, so the patient has been educated. They know how to use their device. They're going to start inputting data. So just for your guys' knowledge, what has to happen is the patient has to set up a LibreView account, and then they have to choose your clinic as the place that they're going to send their information. So that's part of the initial intake. The RN will help them, download the app, set up their account, et cetera, if they have problems with that. And then your RN is going to be watching all the patients that belong to your clinic on their own LibreView dashboard. We don't have the Epic patch yet for Libre to go straight through, so they still have to log into the cloud. So that's some training that the RNs got during their training session. Then at the decided upon time that you put in your plan, your RN will go into the cloud and pull the LibreView report, what's called the AGP report, and put it into Epic for you. There's a standard dot phrase that they're going to use that you're going to get very used to seeing with your results. And so it's going to have a couple things. One, the text of the encounter note that will be in there will have some key metrics in there. So it'll have the GMI, which is the calculated A1C based on the AGP report. It'll have the time and range, and it'll have if the patient had any hypoglycemic events. It'll also have like a little bit of script in there for, if the patient had something out of the ordinary happen, like, hey, Dr. Gaster, the patient was on vacation, so these numbers might look a little funky because they were, eating pasta or something. So that'll be in there so that, you know, when you're in your in basket in between visit in your office on admin time, whatever, and you see it, you get a little bit of a snapshot of what's in the AGP report, and you can decide whether or not you need to look at that right now, or if it can wait until maybe you see the patient for their diabetes follow-up. If you do want to look at the report, it's going to be linked in the encounter. So the PDF of the AGP reports all get scanned into the media tab of Epic, but they are also linked in these encounters. So you can just click it and it'll pop up and you can take a look at it if you want to. And then, so just be ready to see these in your in basket. I think that's probably the biggest thing I want to mention. We also got this built out as part of this program before, since these are not real lab results, like the GMI is not a lab result, right? It's like a technical data point from the device. We can't put it in the lab section of the EHR, but we are able to put it in this flow sheet. So if you guys use flow sheets in Epic, you would just pull up the flow sheet tab. And the first time you want to access this, you're going to need to search for it because it's not going to pop up automatically. And if you put in diabetes MA note in there, it'll pop up and you can favorite it. And then it will have the GMI, the time in range, and the time below range as key metrics. So if you have multiple reports, you can see it trended over time in the flow sheet. So, you know, that was something we didn't have for the pilot because it did take a little bit of Epic build. And before, if you wanted that, you had to just go in and like open each encounter and like scribble down the number and then look at the next one. So this is kind of a nice graphic way to look at how your patient's been improving. Any questions about what happens after you send the patient for the program and then the data upload? And then the next thing we're going to talk about is specifically AGP reports.
So the super easy thing is just to plop the report into media. But then the additional, boy, wouldn't it be awesome and great, is to then take discrete data from there and have the RN or somebody actually type in each of those values into the flow sheet.
Yeah, so the RN will do that. That's part of the RN workflow to put it in the flow sheet. So it'll be available for you. I also, maybe this is a good time to just mention, like, this does not take the place of regular A1Cs, obviously. So you can kind of see if that real A1C that you draw like every 3 months or so syncs with the GMI. So,
Crystal, can I ask a quick question?
Yeah.
Just wondering, you were saying that the Epic interface with the devices has not been upgraded across the system yet. Is there an ETA for that?
That's a great question. I would probably ask Savitha. I know DCC obviously has been asking for that. Right now we are working on, I think there's actually an Epic intake. I want to say Phil Hall told me that. We're working on a Google Fit Apple Health Kit patch right now for more for blood pressure readings, but there is a patch for Freestyle Libre that would import the data straight. But yeah, I don't know the details as to why that hasn't been. I don't know if it's just stuck in the queue of like post D1 million projects. That's would be my guess, but yeah, I know that there's an intake.
And just so that, like, my naive sense of what GMI is, so that's supposed to be like a rough estimate of A1C, but so like 28% is not.
Yeah, that would be insane.
Right. Okay.
Yes.
Okay.
This is an IT analyst typing in something for a screenshot,
Okay.
not a real GMI.
Just want to make sure.
If you saw that in your note from the RN, you'd be like, oh,
something's wrong.
You know, open up that AGP report. Yes.
Okay. That's supposed to be an A1C-ish.
Yeah, A1C-ish number. Yeah. Yeah. All right. Well, why don't we jump into just kind of like a quick overview of AGP reports? That's a good segue, Brock. So this is it. It's a one-page report. And, you know, obviously we're all learning something new. I do think that it kind of sinks and makes sense from a logical perspective once you kind of dig in a little bit. But we're going to look at kind of the three main areas of this report. We're going to look at this upper left-hand corner, which has the GMI, which is like one of the key metrics. We're going to look at this upper right-hand corner, which is time in ranges. And then I don't think I'm going to go in detail in the waveforms, but we'll talk about a rubric to kind of look at these, the ambulatory glucose profile for the patient. Okay, so this is that upper right-hand corner right there. And this is time and ranges. Is pretty self-explanatory. But we're going to be looking at time in range, meaning in the actual normal glucose range. That's kind of your main target here. And your goal is greater than 70%. And in the studies kind of validating this technology, time in range of greater than 70% corresponds to an A1C of 7%. So above that, and you're hitting your target. There's time below range. That's more important, obviously, for patients who are on insulin. So you might want to pay attention to that if you're going to be doing this for patients who are taking insulin. And then obviously there's time above range there. But predominantly you're going to be looking at this green bar and then the yellow and the, and the red. Oops. Then the next quadrant, or well, next area is upper left, and this has kind of the key metrics. There are a couple things you're going to pay attention to. First, you're going to look at the date range that this report comprises. You'll want at least 14 days of data with scanning at least 70% of the time for this to be enough data, enough valid data for you to make changes. If it's less than 14 days, or if your patient has worn the sensor or uploaded the sensor less than 70% of the time, you might not actually have enough data to do like medication changes based on that report. So in this example, you can see that this report is 28 days of data, and this patient was incredibly compliant. They wore this for 98% of the time and sunk their data very well. You can sync your smartphone as much as you want, and some patients are very good about doing that, but they only need to do it 3 times a day, every 8 hours. If they do go longer than that, they do lose some data because that's as much as that little sensor can hold. Again, the RN really emphasizes that in the training. So it's going to show you the average glucose there, and then the GMI, which is the calculated A1C based on the data in the report. So obviously, this gives you kind of like a real-time A1C as opposed to waiting 90 days to see if things impacted A1C. And that's really powerful for the patient. You also have glucose variability, another metric that's important for patients who are on insulin. The goal is less than 33%. And this has been shown to, if you can control the variability, you'll have less risk of hypoglycemia. So here's a simple rubric from Savitha. So you're sitting down with the patient, you're going to go through an AGP report. First thing, check and see if there's enough data in this report to make it valid. At least 14 days, they were at least 70% of the time, or uploaded at least 70% of the time. It really is a best practice to go through these reports together with the patient. Again, that's really the power of continuous glucose monitoring, is patient engagement into their diabetes plan. And you can do this face-to-face, you can do this over telemedicine. That's kind of one nice thing about sharing screen. You can actually bill the code for interpretation outside of a visit, in basket time, whatnot. But again, you're kind of missing some of the, power of this if you don't talk through it with the patient. And then obviously you can bill this code along with your level of service code for the visit. So if you billing a level 4, then you just add the E&M code on for the interpretation of the report. You're going to look at the waveforms on the bottom of that report and identify, okay, when do you eat? What time do you go to sleep? Do you exercise? What time do you take your meds? And then look for patterns. Actually, that patient I was mentioning with Medicaid that we got 2 free sensors, it really helped her realize that all of her hypers were in the evening. And the biggest thing she did, even though she was at goal, actually her A1C was at goal, was that she shuffled her meals around a little bit because she didn't like the idea of having any hyperglycemia. So anyway, she was able to kind of fix that nicely. And then, look at areas where there's hypers or hypos and try to figure out, what do you think is contributing to that? And then, you make an action plan based on the interpretation. We have this nice dot phrase, the RPM interpretation note, that will make sure that you kind of hit on all the things you need to be able to compliantly bill out that code. It's actually very simple to do that. And then you'll CC that to your RN so he or she knows, what's going on and what they can emphasize with the patient if there are any changes to plan. And, if you're going to continue them in the program. Like, okay, we're going to do another month of this. So then your RN will know, okay, I need to be looking for these reports for another couple times over the next month. Changes to care plan. So we've got some nice tools for the RN to use to just kind of standardly document, what they've done and to track their time. They do have to track their time if they're going to bill. Obviously, your clinic's not going to do that, but the other clinics are tracking time. I mentioned the interpretation note already. And then we have 2 AVSs. So one is that one I showed you for the beginning when you intake a patient and you just want them to have some simple FAQs about the program, what to expect next. And then there's also a treatment AVS that is just a generic, we made these changes to your plan today. Thank you for wearing your sensor. I will like to see you in a month, that type of care planning type stuff in there. And then again, for the between visit communication, you'll be just looking out for that in your in basket. And your RN will be using a variety of different types of encounter types. This is the billing and coding grid. Really, the code that you need to be most familiar with is this 95251. This is the interpretation, and you can build this every month. I think for those of us who are kind of starting out with this, it's kind of nice to just have this cadence of, I'm going to see you once a month. I'm going to bill this out once a month. It just keeps your brain from getting scrambled about like, oh my God, like when the heck did I bill this out last? Can I bill it? Again, we are doing a lot of advocacy with Epic to try to get them to build some better RPM billing modules. So, and I've heard from other friends at other AMCs that they've sent similar advocacy to Epic. But anyways, right now there's not a great RPM time tracker in Epic. So we got to kind of do this manually.
And Crystal,
yeah.
Crystal, do you have a sense of what the RVU is for that?
Yeah, it's 0.7.
0.7. Wow. So it's a lot.
Yeah, I know for us, it's a lot.
Yeah, I mean, yeah.
Don't say that to, one of the proceduralists, right?
Right.
Yeah. So yeah, 0.7. And then what the staff that can bill incident to are billing are these other codes to kind of support their time. And it's actually really, really kind of validating, let me just say. Our RNs and our RNs and RDs who are billing this feel really good because, they spend a lot of time for our patients. And these are in increments of 20 minutes. The max you can bill per month is 40 minutes. This is what the job aid looks like. It's only 8 pages long. So if you want the whole thing on your desk, you can print it without feeling too guilty. It also lives electronically on the SharePoint site and we'll get you all these links. If you want to just print some select things to kind of have at your workstation, I would say number 9, just so you remember the code you're supposed to bill. Oh, and then one thing, let me just say this as a provider who never uses charge capture, you have to enter this in charge capture. It's not in the little box on the bottom. So familiarize yourself where charge capture is. You got to put this in there. Otherwise, you're going to keep putting it in there. You're not going to find it. And then number 10 is the smart text summary, just so you can remember all of those smart text names that just like roll off the tongue. I would say that is feedback we've received from some of the clinics. And I just apologize. There are like literally a million smart texts in Epic. You have to name it something very unique. Otherwise, there's just going to be 20 other smart texts that are too similar.
And so Crystal, just so this is not just an additional billing code as like a modifier. This is something that's a billing code that has to be entered into charge capture.
Yep.
Ooh.
Yep.
Oh,
so
okay. Oh.
Jake can help you find that, Brock.
I know. No, I can find it. It's just like one other mental leap to get there.
I know.
Wow. Okay.
Yeah. Additional resources. So again, here's the link to Savitha's awesome talk about interpretation of AGP reports. This is all of the resources you could potentially want for CGM RPM, including the job aid lives there. This is the training video from Abbott. And this is what is in the job aid if you print section 9 for the smart text, but this is all we have to help support easy documentation within Epic. And I'll pause there. Mika's going to send out this deck that I just went through. He'll send Jake and Candace the links. He'll send you the link to the recording of this training as well for people who missed it today.
Could you just go back one slide?
Yeah.
Great. You can stop there and do questions. I just want
Yeah.
to write this down.
Yeah, go for it.
Okay.
Let me just check the chat and make sure that there's anything. Yeah, thanks. Thanks for the commentary, Jake. Any questions I can answer? Maybe one other highlight. I know Tammy's on right now, but there are office hours it's been mostly the nurses and RDs have come to these 30-minute sessions to just, oh, I had this happen. Can you help me troubleshoot it, etc. But it's also available, for, Jake, maybe Candace, if there's some sort of clinical thing, we do have standing office hours. Otherwise, for questions about technical stuff, like, I don't know, why is Epic not sharing the smart text with me or something like that? Let Mika know. He's been interfacing with IT for us. I know Kate already reached out to him about smart text. Anything clinical, feel free to reach out to me. I'm happy to field those questions and answer them if I can, or get you an answer from someone who's smarter than me if I need to.
And Tammy just clarified that the office hours for RNs are on Tuesdays at 11:30 a.m.
And then just one more quickie. So like for somebody who is like super savvy and we haven't like gone through the steps of connecting them to the GIMC Libre website connection, can a patient just print out their own report and bring it to their visit?
They totally can.
Okay.
And then you would just have to, can I have that? And scan it in,
Okay.
Yeah, but they can totally do that. And in fact, a lot of the nurses are like, the patient just showed up with the sensor on and their app already downloaded and tried it out at the visit. So, yeah.
Okay. I mean, that's not too different than a patient bringing in their glucose log.
Yeah.
Right.
Exactly.
I mean, and so, does it have to be scanned into media in order to bill?
Yeah.
Is that like a billing requirement? Okay.
It's a billing requirement that
so
we
if
have.
they do that, make sure that you grab it.
Yep. Exactly. You snatch it.
Okay.
And let me just give you guys some FAQs that have been asked for things. What about patients with impaired glucose tolerance? I know you have those patients with a strong family history, their A1C is flirting with 6.4 and they're very alarmed. This is where you get to be a practitioner and make a good clinical judgment. Please do not enroll them in the program though, because, we absolutely don't want to be like billing anything funky on that. But, if you think that's going to be a good tool for engagement for that patient, you can make your clinical judgment. Just know insurance will not pay for it for IGT. So your patient will be having to, pay cash for it. All right. Well, you guys know where to reach me if you need anything. Otherwise, we'll be very excited to see where this goes. We started rolling this out for real in January, and we've been receiving about 20 referrals a month to CGM. So very cool. And, I really hope that this is something that helps your patients.
Well, thank you so much, Crystal. I know this has been a ton of work, and we're super excited to make our way, find our own version of this.
Yeah.
And there really is just like this sense of like, it's going to be so much easier. Like, I mean, right now we're like struggling through like forcing this right now, but I mean, just, it can't be that much longer before like so much of this is fixed where coverage is easier and the Epic patch is there and like, just like all of these, like, and it does seem like so silly that you have to go to charge capture to enter this code. Like somehow Epic's got to be able to like enter the code in where the other place where you enter the code.
Yeah, actually, that's kind of an interesting question. I wonder, Mika, can we track that? Can we